Welcome to the Johns Hopkins Women's Health Podcast, A Woman's Journey, Insights That Matter. I'm Kelly Gear-Ripken, and I invite you to listen to Johns Hopkins specialists discuss the latest topics in women's health. Now here's your host, Lillie Shockney.
Hi, this is Lillie Shockney from A Woman's Journey at Johns Hopkins, and this is our podcast, Insights That Matter. In this podcast, I am joined by cardiologist Dr. Ilan Wittstein. Dr. Wittstein is the foremost expert in broken heart syndrome and also known as stress cardiomyopathy or takotsubo cardiomyopathy. He also is the director of the Heart Failure Fellowship Training Program at Johns Hopkins and the director of Cardiology International. So welcome, Dr. Wittstein, and thank you so much for joining us today.
Well, thank you very much for the invitation. It's a pleasure to speak with you today.
And this is Heart Month that you and I are talking to our audience. So that seems appropriate that we will be discussing a syndrome that you specialize in that is called broken heart syndrome. And I know in this case, you're not talking about two people that were in love that aren't in love anymore. Can you tell us what broken heart syndrome is?
Broken heart syndrome is a unique condition that we started seeing over 20 years ago. In the modern era, when we use that term, we're referring to a syndrome where there is sudden heart muscle weakness and heart failure following some type of stress. Now, that stress can be either emotional or it can be a physical stressor, the type that you might encounter with a serious medical illness. And whether it's emotional or physical, the heart muscle suddenly weakens and can precipitate heart failure symptoms, which can be in some cases life-threatening.
Wow. So tell us a little bit more then about the types of emotional stressors that could trigger this type of syndrome.
When we first started seeing cases of this, we thought it was purely a syndrome that occurred after emotional stress. I remember the first patient I saw was a woman whose mother had just died. The second case I saw was a woman who had been in a very scary car accident. The third person was a surprise reunion. And the fourth person, believe it or not, was a woman who walked into a dark room and about 70 people jumped out and screamed surprise at a birthday party. And after seeing 3 or 4 of these cases, we said, wait a second, this is a new condition of heart muscle weakness and heart failure that occurs after severe emotional stress. What we learned subsequently in the years that followed was that this can also happen after a variety of physical stressors. But the emotional triggers are fascinating. Probably the most common one is grief. In fact, it's what originally led us to nickname this broken heart syndrome, was that we were seeing people who would come into the hospital with this condition after the loss of a loved one. We saw a lot of grief-related broken heart syndrome, but we've also seen it following severe anger, severe surprise, severe sadness. We've seen people who have come from funerals with this condition. Any one of the major emotions can precipitate this. And in fact, it's even now well described after strong positive emotions. There are reports of people who have won the lottery who have developed this, or have had a very happy reunion that can actually cause this. So in the majority of cases, it's a strong negative emotion, but even at times a strong positive emotion can lead to this.
That's fascinating because we usually think of emotional stressors as all being negative, of something unpleasant. Here somebody's having a surprise birthday party and it hurls her into this situation. So those are all what I would call acute stressors, that they happen rather suddenly, probably very much unexpectedly. Does chronic stress have any role in this type of syndrome?
Yeah, well, you're exactly right about that. Typically, this syndrome is precipitated by acute stress. We do believe, and there is some evidence, that people who are under chronic stress are more susceptible to an acute event. But it's important to realize that this is not a condition that people walk around with for weeks or months. This is something that happens suddenly. Your heart muscle can be normal at 10 o'clock in the morning and abnormal by 10:15. So it happens very quickly, but I think you're 100% right that it does seem that people who are under chronic stress are more susceptible to these sudden acute events.
And so you also mentioned that there are physical stressors that can also trigger this to happen. I'm thinking about, we're in the middle of winter with snowstorms and in some cases, blizzards and such. And I was watching on the news last night up in the Northeast when they had a Northeaster blow on up into Boston and into Maine. And for the first time I can remember, I saw on the news women who looked like they were in their 70s out shoveling very deep snow. And the reporter went over and was interviewing them. And I'm like, isn't there some young teenage boy on your block that can help you with this? But could that possibly be a physical stressor of shoveling snow that normally a woman would not be doing on a daily routine? I hope. Is that the type of physical stressor you're referring to?
There are a wide variety of physical stressors. And when we say physical stressors, one type is exactly the scenario that you described. We've actually seen people come in with this after very strenuous exercise. In fact, shoveling snow has been one of those cases. Even people exercising vigorously at the gym, we've seen precipitate some of these cases, but those are actually the minority of cases. Typically, when we say physical stressors, we're referring to some type of physical stress that is associated with a medical disorder or a medical disease. And those could include, for instance, having a high fever from an infection or having a gastrointestinal bleed. Having a stroke, as it turns out, is a very common trigger of this syndrome. So you'll see it in the hospital a lot from people who are suffering from medical illnesses. And in fact, one of the more common precipitators of this is going to surgery. People will go off for surgery, they'll have a procedure, they'll get anesthesia, and they'll actually come out with the signs and symptoms at times of broken heart syndrome. So it can be anything really that puts the body under a great deal of stress, whether it's a psychological stress or some type of physical stress, or both can cause this syndrome.
What types of symptoms would a patient take note of that would say, gee, I think I've got something going on here and I better get myself someplace?
If you're a person out in the community who suffers some kind of emotional trigger, the most common symptom is chest pain. It can be very difficult, in fact, impossible if you're sitting at home having chest pain to know whether this is broken heart syndrome or a true heart attack. So chest pain is the most common symptom. Shortness of breath is probably second. People can describe lightheadedness and dizziness. Some people will describe nausea, or they'll feel like their heart is racing. If you're out walking around in the community, those are the types of symptoms that are most common. If you're in the hospital suffering from a medical illness or going to the operating room, obviously, if you're under anesthesia, you may not experience any symptoms, and which can actually be somewhat problematic because there's not always a warning signal. But if you're out in the community, certainly the most common symptom is chest pain.
Wow, I can see how that could be, I'm going to say confused or kind of misinterpreted as probably being a heart attack. So let's say that someone is out in the community and this happens to them and the person they're with calls 911 and the ambulance arrives. Is the ambulance crew able to distinguish between this is a myocardial infarction, this is a heart attack, versus this is stress cardiomyopathy?
That's a great question. And the simple answer is typically no. The ambulance crew that arrives will not be able to tell that this is stress cardiomyopathy versus a heart attack. In fact, the EKG that's typically done on someone having chest pain will frequently look exactly like a serious heart attack. It's quite the mimicker at times of a heart attack. So the paramedic crew may actually do an EKG and then immediately call to the emergency room and say, we're bringing someone in who's suffering a heart attack. It really takes a series of further tests that really can only be done in the hospital to distinguish one from the other.
My goodness. We're now entering our third year of what I'm going to call living with COVID-19, which has certainly been a great stressor, chronic stress, and in some cases acute stress for some families. People worrying that they're going to get this particular virus or worrying that someone that they love is, or even losing a family member. It's been so disruptive to our lives that I'm curious to know what role might it play with the development of stress cardiomyopathy. You mentioned a high fever, for example, which made me think about this particular virus too.
It does look like COVID has brought a resurgence of cases of stress cardiomyopathy. And there are probably two reasons for this. The first is exactly like you mentioned, that this is a stressful time to be living anywhere because of the pandemic. And there are certainly numerous reports of people who have come in with stress cardiomyopathy due to feeling socially isolated and lonely. Those cases have been reported, but there have actually been bigger studies now showing that the number of cases of stress cardiomyopathy in large hospitals has gone up significantly during the COVID era. There was a study out of Cleveland Clinic that showed a significantly increased number of cases compared to the pre-COVID era. So we do believe that that's one of the reasons, this feeling of social isolation and in some cases depression and despair that has led to an increase in cases. But there's another very compelling reason. If you actually look at all the physical stressors that can cause stress cardiomyopathy, one of the most important ones, and probably the one that's most common in causing stress cardiomyopathy, is pneumonia. So things that can affect your ability to breathe and your ability to get oxygen into the system are very potent triggers of stress cardiomyopathy. So here we have this pandemic where the number of cases of pneumonia has just gone up significantly. We believe that that's a major reason why we're seeing a lot of these cases. We're seeing cases both from the emotional side of COVID and also the physical illness side of COVID.
Oftentimes when presentations are being given and we watch them on TV, maybe on the news, or even could be a special session, perhaps by Dr. Fauci or someone else, talking about pneumonia, talking about the heart without saying a specific diagnosis of the heart, but just said that it's taxing on the heart. I think this gives great insight to our listening audience as to what the scientists may be, in fact, referring to. And that also tells me that you're dancing as fast as you can dance at work, because I'm sure that you are seeing a lot more newly diagnosed patients and having to also advise and do medical consults for other doctors elsewhere that are not going to be as expert as you are with this particular syndrome. When we look at the heart muscle, what is it about the heart that stress triggers a weakening of that heart muscle?
Yeah, so that is one of the very fascinating questions that even after 20 years of being involved with this syndrome, is hard to give an answer that everyone would agree on. We think we understand the major pathophysiology and mechanism of heart muscle weakening in this syndrome, but nobody's 100% sure. But I can certainly tell you what we think the major actors are here. When a person is under severe stress, whether it's an emotional trigger or a physical trigger, the body releases stress hormone. And these are called catecholamines, and people may be more familiar with terms like adrenaline and noradrenaline. So adrenaline is released. It's the fight or flight hormone. It's what we produce when we have to get busy, when we have to run, when we have to fight, when we have to be careful and angry, response to anger. It's the hormones of stress that we produce. We know that these are important hormones and that our heart needs to respond to these hormones by beating stronger and beating faster. That's how we're going to survive a stressful, potentially dangerous situation. But it turns out that these hormones in excess can be dangerous to the heart. What we believe is that these hormones can do a couple of different things to the heart muscle. It's normal for adrenaline to bind to the heart and have calcium flow in and out of heart cells. That's how heart cells know to contract. But what happens with this syndrome, we believe, is that an excessive amount of adrenaline binds to the heart and causes a flooding of calcium into the heart muscle cells. This leaves those cells in sort of a contracted state, but they can't relax and then contract again. So they become very dysfunctional temporarily. So all of a sudden you have a heart that's full of cells that aren't contracting the way they're supposed to normally. We also believe that one of the aspects to the mechanism of this disorder is the small blood vessels around the heart muscle are affected by significant stress hormone release. The heart is supplied by blood by three major arteries called the coronary arteries. But these don't seem to be the arteries that are involved in this condition. It actually appears that it's the tiny little blood vessels around the heart, the ones that we call the microvasculature. that also supply the heart with blood. And when stress hormones are released, there seems to be a constriction, a tightening of these little tiny blood vessels that causes a decrease of blood flow to the heart muscle. This sudden decrease of blood flow is what we believe causes the chest pain and also leads to this sudden muscle weakening that we see. So it's probably a combination of those two mechanisms, both precipitated by this sudden surge of stress hormones released into the bloodstream.
So let me ask you a couple questions regarding that I'm sure our listening audience is wondering about right now. They may have elevated cholesterol and they're on medication to help them get their cholesterol down, probably have been advised to go on a diet that would also help reduce that. Does cholesterol play any role with this?
Well, it's a good question, but probably the simple answer is no. In fact, when we think about cholesterol and heart disease, we think about plaque buildup in the arteries around the heart. We have these three big coronary arteries, again, that supply the heart with blood. And as cholesterol levels go up during our lifetime, we develop plaque inside these arteries. And if this plaque becomes severe enough, it can limit blood flow to the heart and cause heart attacks. Well, one of the interesting things that we saw very early on with this syndrome is that many patients with stress cardiomyopathy don't have any plaque in their arteries. They actually have arteries that look quite good. And so we knew early on that this was likely a separate mechanism from the typical thing that causes a heart attack. So certainly people with stress cardiomyopathy can have elevated cholesterol, and they can even have some plaque in the artery. But we think it's a completely different mechanism from what causes what you would consider a normal heart attack.
So those little tiny vessels are small but mighty, for sure.
Exactly.
Another question for you is related to your comment about calcium. A lot of our listeners, I am positive, are taking calcium citrate to prevent or to manage their osteoporosis. Does oral consumption in the form of a pill or food rich in calcium have any influence in what is going on within the heart related to calcium?
The calcium that flows in and out of heart cells is essential for the heart to do its job, to contract, and therefore be a pump that supplies blood to the rest of the body. We don't think that there's any relationship between the calcium supplement that you're taking and your risk for developing broken heart syndrome. So certainly if you're on calcium for osteoporosis reasons, or if you have low calcium levels and your doctor has prescribed that, absolutely you want to be taking that calcium, and you shouldn't be worried that this is going to increase your chances of getting broken heart syndrome.
How would I be able to tell when my heart is pounding from some anxiety that I'm experiencing, perhaps, if that's okay and I can just wait it out? Or do I need to call somebody and get some urgent help? How do our listeners know if I have this happen, I better call 911 or I better get to the ER or do something, versus, no, it's okay, let me just ride this out and see if I feel better in 15 minutes.
Stress can cause a lot of symptoms in the chest area. People can be under stress and develop extra heartbeats. They can feel their heart jumping around. Some people will even develop rhythm abnormalities like atrial fibrillation in response to stress, or extra heartbeats, what we call premature atrial or ventricular contractions. And this may feel like your heart's jumping around. That can sometimes be typical for a person. A person will sometimes tell you, yeah, I get those kind of funny heartbeats all the time. And so you have to know if that's something that you get a lot or if that's something that you're experiencing for the first time. But I think in general, if you're experiencing the sudden onset of chest pain in the chest, especially if that's something that you're not familiar with and it's a symptom that you've not had before, that is always worth an evaluation. I often tell people to take a look at themselves in the mirror or to have somebody who's with them take a look at them. Because frequently when you're experiencing this condition or any type of heart attack, you don't look normal when you're going through this. So all of a sudden you're having chest pain, you may look pale, you may look agitated, you may even break out into a sweat. Those kinds of signals are your clue that it's time to get to the emergency room and to get some help. I guess the simple answer is if you suddenly experience a symptom, particularly if it's chest pain, that feels wrong and is not something that you're familiar with, get evaluated. Because again, there's no way to tell when you're having these symptoms if it's broken heart syndrome or if it's a heart attack or if it's simply indigestion. You have to get an evaluation to have that determined.
I'm sure that there are quite a few people that have panic attacks that would also be concerned. There certainly are ways to manage panic attacks. If anyone out there in our listening audience has been experiencing panic attacks, that doesn't mean that that's something that you have to live with and that you should be evaluated, and your doctor may refer you to a psychologist to help figure out how to manage those so that they are not disruptive to your life. So we've learned from you that this happens more to women than to men. Why do you suppose that is?
After the first couple of months that I was seeing patients with this syndrome, we looked around and we said, boy, this affects mostly women. We had seen about 20 people with this. This was like 20 years ago. 19 out of the first 20 that we saw were women. And this has held true over the past 20 years. Now there have been thousands and thousands of patients with this syndrome reported. And it is still the exact same breakdown that it was back in 1999. It is 90% women who present with this condition. And that is true in just about every series that's been reported over the past 20 years. Of the people who get this syndrome, 90% are women. And whenever we see something like this, we automatically start asking, is there some kind of hormonal influence that's causing this syndrome to occur? What are the effects of sex hormones on cardiac, on heart function? Is that somehow related to this? Well, in addition to the fact that most of the people that get this condition are women, we've also noticed, and we noticed this early on, and again, this has held true for 20 years, that most of the women are postmenopausal. So the average age of stress cardiomyopathy is probably about 60, and the risk of developing stress cardiomyopathy goes up 5-fold after the age of 55. So it's not that you can't be a 25-year-old woman and get this condition, but it's certainly less common. The vast majority of people that we see coming in with this are perimenopausal or postmenopausal women. And that, of course, that makes us ask the question, what is it about being perimenopausal that could be important here? Well, we know that the female hormone estrogen does a lot of important things. And when it comes to the heart and to blood flow to the heart, estrogen is actually very important. I remember when I was in training, one of the doctors that was on faculty here was doing research injecting estrogen down coronary arteries around the heart. And you would see those arteries get much bigger, and blood flow would increase to the heart quite significantly. We know now that estrogen not only is important in allowing better blood flow to the heart, it actually is very important in helping those little microvessels that we talked about earlier do their job. When there's more estrogen around, those microvessels can get bigger when they're supposed to get bigger. And when there's less estrogen around, those little blood vessels tend to constrict and cause a decrease of blood flow to the heart. And I also mentioned before that calcium flows in and out of the heart. Estrogen can actually have a protective effect for the heart against those stress hormones. Those catecholamines that I mentioned tend to surge through your bloodstream when you're under stress. Estrogen is protective. And when estrogen levels decline, postmenopausal women are much more susceptible to the effects of these stress hormones.
So one of the things that happened, it's been more than a decade ago now, was almost 2 decades, gracious, time's flying by, isn't it? Is that family practitioners and gynecologists have been advised to not be so quick with writing on a prescription pad hormone replacement therapy for perimenopausal and postmenopausal women because it increases risk of breast cancer. Do you think that it's possible you may be seeing more women with stress cardiomyopathy today than, say, you did 20 years ago, when many of those women would have been taking some type of HRT to supplement the loss of estrogen that they have in their body?
It's an excellent question, and it's actually something that I've always been curious about. We'll never be able to prove, but I think it's a fascinating suggestion. And here is the reason why. Back in the 1990s, no one was talking about this syndrome. The only country that was talking about this syndrome was in Japan. And all of their reports were in Japanese journals that none of us read because they were all in Japanese. So when I saw the first few cases of this in the late 90s, there was literally nothing in US literature or in Western literature to help me understand this syndrome. And in thinking back over the years, why did it take until the late 90s, perhaps, to start seeing a lot of these cases? Perhaps exactly for the reason that you mentioned, because it was in the 1990s that all of a sudden it was recommended, hey, stop prescribing all this hormone replacement therapy because it can cause breast cancer and other types of problems. So at some point in the 1990s, there was sort of a mass withdrawal of hormone replacement therapy. And I always wondered if that's what led to us seeing on a fairly large scale this increase in cases of stress cardiomyopathy. So I'd never be able to prove that, but I think it's a very compelling suggestion.
I think if there's a way we could retrospectively look at women that were diagnosed, say 20 years ago, and whether or not they were or were not on some form of HRT, we also might see a correlation with individuals who have a history of breast cancer, because we know anyone with a history of breast cancer is hauled off of estrogen. As a matter of fact, there are 71% of them will be placed on a drug that we consider an anti-estrogen drug, a drug to suppress their estrogen. We want it down to zero if we can get it that low. And with drug therapies, we certainly can. So that's pretty fascinating.
Well,
Is it possible?
It's interesting that you say that. It's actually been shown in the oncology population, in the oncology literature, the numbers of cases of stress cardiomyopathy has gone up and up and up over the years. And actually, one of the groups that seems to be at risk for developing stress cardiomyopathy is the oncology group.
So, as they say, I rest my case. Yes.
Exactly. Yes.
Can a person experience this type of problem multiple times?
I would say that the vast majority of people experience it once. That's what our experience has shown, but you absolutely can get this multiple times. In some series, there's about a 20% risk of developing it more than once. So that's not trivial. I have personally seen patients who have developed it 3 or more times. I remember one woman who had it 8 times in her lifetime. So it is possible to have it multiple times. So that is atypical. The majority of patients have it once, but about 20% will develop a recurrence at some point.
How is it treated?
It turns out that the major intervention is really supportive care. So when you think about what's happening to the heart muscle, it's suddenly becoming a pump that doesn't pump. All of a sudden, it just can't pump blood to the rest of the body. Now, that can be a potentially very dangerous problem. So if all of a sudden you're not able to pump blood to the rest of your body, you can have low blood pressure, you can be in congestive heart failure and develop fluid in your lungs, and other organs in your body can start to suffer if they're not getting the correct amount of blood. We do things to undo everything I just said. So if you have fluid in your lungs, we give diuretics to get the fluid out of your lungs. If your blood pressure is very low, we put people on medications to raise the blood pressure. And in some cases, people who are extremely ill when they come in, sometimes they even need temporary, what we call temporary mechanical support, where we put in these temporary pumps that can actually assist the heart in pumping blood. These are typically not ones that need surgery that can be done in the catheterization laboratory, but it provides the heart with a temporary amount of support until it has a chance to start waking back up again and start pumping. Once it does, the patient tends to get better very quickly. But it's very important that we support people during those first critical hours in order to make sure the rest of the organs in the body are getting the blood that they need.
If someone does not seek medical treatment, this just doesn't seem to be on their radar screen of something that they should go and have addressed. Is there a way to know retrospectively when you're seeing a patient that this has happened to them?
Yeah, so there are some people who actually have mild versions of this. They may have some symptoms, but they don't really think it's anything that they should go to the emergency room for. And actually, they probably experienced a case of broken heart syndrome at home. For a while, there are things that you can see when you look at their heart muscle or their EKG. That can be a clue that they had this. The ECG, which is the electrocardiogram of somebody who has this, can potentially be abnormal for weeks to months afterwards. So a person could come into your office and say, yeah, a couple of weeks ago, I had some chest pain after my loved one died. And then you do an EKG and it looks very abnormal. And you say to yourself, I bet I know what happened a couple of weeks ago. The other thing that you can look at is the ultrasound. It's called an echocardiogram. This gives you actual pictures of the heart muscle. People who have this condition will develop an odd shape of their heart muscle. It'll actually look a certain way, and it starts to get better fairly quickly. So if you wait too long, you might miss it. But if you're seeing it within the first couple weeks of their symptoms, you may actually see that odd shape that's still persisting and be able to say, I think you had stress cardiomyopathy or broken heart syndrome.
Tell me what the long-term prognosis is with a diagnosis of broken heart syndrome.
The prognosis question has been very interesting over the last 2 decades. When we first started seeing patients with emotional triggers, they all seemed to do quite well, actually. No matter how sick they were when they came in, they all recovered. Early on, we were writing things that included things like, hey, people with stress cardiomyopathy do great. The prognosis is excellent. Well, as time went on, other people started writing, wait a second, the prognosis maybe isn't as good as was first stated. And we are seeing people not do as well, et cetera, et cetera. I think what the problem was with the literature on this condition was that they lumped all the patients with stress cardiomyopathy together. And so you were talking about people on the one hand who had emotional stress, but also people who had strokes or who had bad pneumonia, and people were just looking at outcomes. I think what we now know and what we suspected all along is that the prognosis is directly related to why you get stress cardiomyopathy in the first place. It turns out that if it's an emotional trigger that causes your stress cardiomyopathy, the prognosis is actually excellent. It's actually very, very good. And almost everybody who has stress cardiomyopathy due to an emotional trigger does well and has a good long-term prognosis. If, however, the reason you developed stress cardiomyopathy was because you had COVID pneumonia, or you had a massive stroke, or you have a severe medical illness, then clearly your prognosis is not as good. And that's been shown over and over again. And probably the condition that has associated with the worst prognosis are neurologic events. People that have strokes or head bleeds or things like that will frequently develop stress cardiomyopathy, and clearly their long-term prognosis isn't as good. And that's almost certainly due to the fact that they had a life-threatening neurologic event that precipitated it in the first place.
That makes sense. Very much so. Dr. Wittstein, is there anything else you think is important for our listeners today to know about regarding broken heart syndrome, or the official term of stress cardiomyopathy?
One point that sometimes gets missed, not only in discussions like this, but also in the medical literature, is that there is clearly going to be an important discussion about stress susceptibility that this condition is going to elicit. I think a lot of times people hear, oh, this is a condition that happens after stress and women get it more often. Are you trying to say that women are more emotional? And that's clearly not the case here. We know that there is a susceptibility to stress that makes some people much more vulnerable to this condition. There is a condition called microvascular dysfunction, where the little blood vessels around the heart, the ones that we were talking about earlier, are dysfunctional. They don't dilate when they're supposed to dilate, and they don't constrict when they're supposed to constrict. And there are many things that can cause that. High blood pressure, diabetes, high cholesterol can all contribute to that. But some people have very significant forms of this microvascular dysfunction. And so it frequently doesn't take much stress hormone release to set off the chain of events that then leads to stress cardiomyopathy. So while at the beginning of all this 20 years ago, we were saying it has to be a massive stressor that precipitates this, we now know that people who are highly susceptible, who have this microvascular dysfunction, they may have a very minor event that causes the whole syndrome. We've had people come in who had a little bit of an argument with a coworker, or who got a little frustrated at work, or who did something presumably that doesn't seem very exciting, and it precipitates the whole syndrome. And I think what that shows us is that while certainly massive catecholamine release causes it in some people, the highly susceptible people can have a pretty small trigger, or what seems like a small trigger, to precipitate this. And in fact, we know that of all the cases described, about 20% of the patients don't even have an identifiable trigger that doctors were able to identify. So this doesn't have to be something that only occurs when you have a life-threatening stressor. It can occur sometimes with just everyday normal activities.
Are there ways that we can approach stress that can reduce risk?
I've had the opportunity to talk to many, many people who have had this over the years. Some people get this because they're in a highly stressful daily environment. A lot of people, it's work related. And I've had some patients who have decided after they had an event, I am going to remove myself from the stressful environment. And that has worked for them. They have either changed their job or they've changed exactly what they're doing for their job, and they've removed themselves from the very stressful situation. Other patients that I've had seem to benefit from things like yoga, biofeedback, things that can help them reduce their subjective stress levels. And I think that has been beneficial for a lot of people. One of the things that's actually really important and that helps with the function of those little microvessels that we talked about is exercise. After a person recovers from this, I strongly encourage exercise. Now, I don't mean go out and start training for a marathon, but doing frequent, constant, aerobic type of exercise can be very good for those microvessels. We actually encourage that. Sometimes people will come to me and say, my doctor told me not to do anything physical. And I feel the exact opposite is what we should be doing. People should be exercising and getting aerobically fit. It can help those microvessels function properly.
Again, for our listeners, oftentimes people think, oh my gosh, they've told me to exercise. I've got to go get a gym membership and go there 6 days a week, and I don't have time to do that. But if people can start small, 5 minutes in their living room is a great way to start and build up from there and not see this as something mammoth, because ironically enough, if they see it as something mammoth, it may give them stress.
Right. That's exactly right. You don't have to be number one in the Peloton class to be exercising. You can go take a walk. That type of physical exercise is very good for the microvasculature and for the endothelial cells that line our blood vessels.
If we had patients just do one thing that we recommend that they do, whether it be altering their diet or something else, walking would be my pick. If anything that I would want someone to be doing that's going to improve their health for targeted reasons and for general reasons, it's to get out there and walk. During the winter, I know it can be difficult to do. There was a time I would tell people to go to the shopping center, and now I say go to the shopping center, but leave your credit card at home because they're window shopping as they do. And then when they make that circle back, they buy this, that, and the other, which could be a whole nother stressor when they get that bill in the mail. This has been a fascinating discussion, and certainly I think an eye-opener for our audience to learn about something that happens to the heart that I would suspect they had not heard about before, but certainly now can understand and probably relate to it. I also want to remind our listeners, it's not what happens to you, but how you react to it as to what your body's going to do with that stressor, for sure. So thank you so much, Dr. Wittstein, for being a part of our monthly Insights That Matter podcast series today. And we wish every one of our listening audience a healthy heart month and a healthy heart future. Thank you.
Thank you for listening to A Woman's Journey podcast. Join me, Kelly Gear-Ripken, your host, Lillie Shockney, and a variety of Johns Hopkins experts on the first Thursday of each month to learn about medical advances in women's health. A Woman's Journey is grateful for the unrestricted educational grants from HRH Foundation that supports our podcast series, Insights That Matter. For more information about A Woman's Journey's virtual programs occurring throughout the year and our monthly webcasts and podcasts, visit our website, hopkinsmedicine.org/awomansjourney. Like us on Facebook and Twitter, and visit our website at hopkinsmedicine.org/awomansjourney. Until next time, stay well.